welcome to the Deep Dive. Today we're tackling a topic that is, well, utterly universal, something every single one of us experiences. Yet when you really start to peel back the layers, it is just astoundingly complex. We're talking about pain. It's far more than just a simple feeling, right? It's intricately woven with our emotions, our behavior, our very sense of self.
That's absolutely right. I mean, pain is the single most common reason people seek medical attention. It really is the body's essential alarm system, a vital signal of potential or actual disease. And frankly, without it, we wouldn't survive very long.
Right.
So understanding how that signal is generated, transmitted, and processed is absolutely fundamental, not just for diagnosis, but critically for relieving suffering.
And we have a truly comprehensive stack of source material before us today, a real deep dive into the pathophysiology and management of pain. It's a chance for us to really dissect this foundational human experience, exploring those intricate mechanisms, how your body detects and processes pain, what happens when that sophisticated system goes awry, and the strategies we use to try and manage it, from the most basic medications all the way to advanced treatments.
Yeah.
Our mission here is clear: to go deep into this source material and truly master this information, to understand pain like the elite professionals in the field do.
Exactly. We're going to trace the pain signal's journey from the very first point of contact in your tissues all the way up to the brain and, well, the complex ways it's interpreted and even controlled.
Oh, okay.
Get ready, because this is an intense exploration of a core aspect of human life.
Okay, let's unpack this then.
Yeah.
Let's start at the beginning with the pain sensory system itself. It's often thought of as just a warning system, but it's doing a lot more, isn't it?
It absolutely is. While its primary role is definitely protective, detecting, localizing, helping you identify threats to maintain your body's stability, its homeostasis,
Right.
the experience of pain is not purely sensory.
I've always found that fascinating. Our sources really emphasize this duality. It's described as having a sensory component, the actual feeling like stabbing, burning, or aching, but also a powerful emotional one. It can feel terrifying, sickening, and it's immediately linked with anxiety and that intense urge to escape or withdraw.
And when you experience acute pain, that sudden, sharp signal, it triggers a whole cascade of responses. You see behavioral arousal, you become alert, hyper-focused. Then there's the physiological stress response. Your blood pressure and heart rate go up, pupils dilate, stress hormones like cortisol increase.
Yeah.
And there's often a local muscle contraction like flinching or guarding the injured area. It's a full system alert, really.
So that initial response is surprisingly complex. It mobilizes both mind and body. Okay, let's follow that signal. Where does it actually start? In the periphery, right where the injury happens.
Precisely. Out in your tissues, you have peripheral nerves. And these aren't just one type of wire. They contain bundles of axons from different kinds of neurons.
Yeah.
You've got primary sensory efferents bringing signals in, motor neurons telling muscles what to do, and sympathetic postganglionic neurons, part of your automatic nervous system.
And the cell bodies for those primary sensory efferents, the ones carrying signals from the body to the spine and brain, they live in those little clusters just outside the spinal cord, right? The dorsal root ganglia.
That's the spot. Exactly. And these primary efferent fibers are incredibly diverse. They're classified by their diameter, whether they have a myelin sheath, which makes signals travel faster, and their conduction speed. You have the large diameter myelinated A beta fibers. These are the fast ones.
Right.
They respond to things like light touch or gentle movement. And crucially, in a normal, healthy state, activating these A beta fibers does not produce pain.
So A betas are your touch sensors, not your pain sensors.
Okay, exactly. The dedicated pain messages are primarily carried by two other types: the smaller diameter, still myelinated A delta fibers, and the even smaller unmyelinated C fibers. Both A delta and C fibers are found pretty much everywhere: skin, muscles, joints, organs. Some tissues, like the cornea of your eye, are only wired up with A delta and C fibers, which helps explain why even a tiny scratch there is just excruciating.
Right, okay. So A delta and C fibers are the ones carrying the pain signal. And a key term here is nociceptor. Our sources say most A delta and C fibers are nociceptors. What actually makes a neuron a nociceptor?
Well, a nociceptor is a primary afferent neuron specifically designed to respond maximally to intense, potentially damaging stimuli, what we call noxious stimuli. When activated, these fibers produce the subjective experience we call pain. And the evidence is really clear. If you selectively block conduction in these A delta and C fibers, you lose the ability to detect painful stimuli. They are the body's dedicated pain detectors.
It's like the fire alarms of the nervous system. Got it.
Yeah.
What kind of stimuli set off these alarms?
They're often polymodal, meaning one nociceptor can respond to several types of danger. Think intense heat, intense cold, strong mechanical force like a pinch.
Mm-hmm.
Significant changes in pH, like tissue becoming acidic, and a whole host of chemical irritants. These chemicals are often released right at the site of injury or inflammation, things like ATP, serotonin, bradykinin, and histamine.
Bradykinin or BK is mentioned specifically as a key player. And there's a particular channel involved too, TRPV1.
Yes, the TRPV1 channel, often called the vanilloid receptor. This is a critical protein embedded in the membrane of many nociceptors, particularly C fibers. It's famous for mediating the burning sensation from heat, but it's also activated by acidic conditions, certain inflammatory molecules, and perhaps most famously, capsaicin.
The stuff in chili peppers.
Exactly, the stuff that gives chili peppers their heat. When you eat a hot pepper, you're essentially activating your pain receptors via this channel, kind of tricking your brain into thinking your mouth is on fire.
That explains why really spicy food feels like actual pain.
Wow.
Okay, so we have these specialized sensors, the nociceptors, wired to detect danger. But the system isn't static, is it? Especially when there's ongoing injury or inflammation. This is where it gets really complex and clinically important. Sensitization.
Sensitization. Yeah, this is when the pain system essentially becomes hypersensitive. If tissues are subjected to intense, repeated, or prolonged noxious stimuli, particularly when there's tissue damage or inflammation, the nociceptors don't just keep signaling, they actually change. Their activation threshold lowers, so it takes less of a stimulus to make them fire, and when they do fire, they fire at a higher frequency for the same stimulus intensity.
So the alarm goes off easier and screams louder, basically.
Yeah, that's a great way to put it. Exactly. Yeah. And those inflammatory mediators released at the injury site are central to this. Bradykinin, nerve growth factor, prostaglandins, leukotrienes, they all contribute to this heightened state of excitability.
Our sources break down two types: peripheral sensitization and central sensitization. Let's start with peripheral. What's happening there?
Peripheral sensitization happens right at the nerve endings, out in the damaged tissue. Those inflammatory mediators bind to receptors on the nociceptor terminals and trigger intracellular signaling cascades, like a chain reaction inside the nerve cell.
Okay.
This leads to the production and insertion of more ion channels into the nerve membrane channels that are crucial for generating electrical signals. Having more channels or channels that are more active makes that nerve terminal more excitable. It lowers its threshold for mechanical, thermal, and chemical stimuli. The nerve ending becomes kind of jumpy and overly responsive.
And central sensitization, where does that happen?
This occurs in the spinal cord, specifically in the dorsal horn neurons that receive input from the nociceptors. If those peripheral nociceptors are sending intense prolonged signals because of inflammation or injury, it actually enhances the excitability of the spinal cord nerve cells they connect to. It's almost like the volume knob for pain transmission. The spinal cord gets turned way up and maybe even gets stuck there, making it hard to turn back down.
Wow. So the problem isn't just at the injury site. The spinal cord itself becomes hyperactive. And the consequences, well, they're huge in the clinic, aren't they? This leads to allodynia and hyperalgesia.
Crucial terms for understanding clinical pain, absolutely. Allodynia is when a stimulus that is normally completely innocuous, not painful at all, is perceived as painful. Our sources give the classic example: a gentle touch or even a light slap on severely sunburned skin, it can be agonizing. That's allodynia. The system is misinterpreting a normal touch signal as pain.
Okay, and hyperalgesia.
That's when a stimulus is noxious, but the pain perceived is significantly increased in intensity compared to what it normally would be. So maybe a pinprick feels like a searing stab. Sensitization, both peripheral and central, is really the underlying mechanism for that tenderness, soreness, and exaggerated pain response we often see after injury or during inflammation.
One place where sensitization is particularly striking is in deep tissues, like our internal organs, the viscera. Our sources mention these are normally quite insensitive to things like cutting or temperature changes, compared to skin anyway.
They are, relatively speaking, but inflammation in visceral organs can make them exquisitely sensitive. And this brings up a really fascinating concept: silent nociceptors.
Silent nociceptors, they sound a bit mysterious.
Well, they're A delta and C fibers that innervate deep somatic structures and viscera. In healthy tissue, they are normally unresponsive or have very high thresholds for activation. They're essentially silent to most stimuli.
Okay.
However, in the presence of inflammatory mediators, things like low pH, prostaglandins, leukotrienes, bradykinin, these silent fibers suddenly wake up. They become sensitive, particularly to mechanical stimulation like stretching or pressure.
Wow. So they're like backup pain alarms that only get switched on when there's serious trouble deep inside.
That's a good analogy, exactly. Their activation likely contributes significantly to the severe pain and tenderness that can originate from otherwise relatively insensitive deep structures or organs when they become inflamed or damaged. It's not just turning up the volume on existing signals, entirely new pain pathways are being recruited.
And this ties into another key point from the sources. Primary afferent nociceptors aren't just passive sensors sending signals in. They actually have a neuroeffector function.
Right. They actively participate in tissue protection and the inflammatory response. They do this by releasing powerful chemical messengers from their peripheral terminals when they get activated. Think of them as part of the local defense and response team, not just the lookout sending a message back to headquarters.
Interesting. What kinds of chemicals are they releasing?
The sources mention polypeptide mediators like substance P, calcitonin gene-related peptides, CGRP, and cholecystokinin. Substance P, which is an 11-amino acid peptide, is particularly well studied for its peripheral actions.
And what does substance P do out there in the tissue?
It does several things. It's a potent vasodilator, meaning it widens blood vessels, which causes redness and warmth. It triggers mast cells, immune cells common in tissues to degranulate and release histamine and other inflammatory substances.
Okay.
It also acts as a chemoattractant, drawing in other immune cells like leukocytes, and it increases the production and release of other inflammatory mediators.
So the pain fiber itself is releasing chemicals that actually fuel the inflammation. That sounds like it could create a vicious cycle, contributing to that sensitization we were just talking about.
Precisely. It's a positive feedback loop that can amplify both the inflammatory response and the pain signal. Our sources note, for example, that depleting substance P in experimental arthritis models actually reduces the severity of the joint inflammation and pain.
Okay, so we've explored the periphery, the first responders, how they get sensitized, how they even contribute locally. Now let's follow that signal up into the central nervous system. The primary afferent axons enter the spinal cord via the dorsal root and make their first synapse in the dorsal horn gray matter. This is the spinal cord's main pain processing hub, right?
Yes, the dorsal horn is the critical relay station. Here, the primary afferent nociceptors release neurotransmitters to excite the second-order neurons, the spinal cord neurons, that will carry the signal further up towards the brain.
What neurotransmitters are involved there?
Glutamate is the main excitatory neurotransmitter. It causes rapid, fast transmission across the synapse. But substance P and CGRP are also released here by nociceptors, and they cause slower, longer-lasting excitation of those dorsal horn neurons.
And the wiring here is really important. Our sources highlight the concept of convergence. What does that mean?
This is absolutely fundamental to understanding things like referred pain. In the dorsal horn, each incoming primary afferent neuron can connect with many different spinal neurons. It branches out. But maybe even more importantly, each individual spinal neuron receives input from many different primary afferents. It's like multiple different roads all merging into the same intersection.
And this convergence explains something we've all probably experienced or heard about.
Yeah.
Referred pain. Feeling pain somewhere other than the actual site of injury.
Exactly. The convergence projection hypothesis explains it elegantly. Primary afferents from internal organs, the viscera, or deep somatic structures like muscles and joints converge onto the same spinal pain transmission neurons in the dorsal horn as primary afferents coming from the skin. And this convergence pattern is organized by spinal segment.
Okay, can you give us an example?
Yeah, a classic one is the central diaphragm and the shoulder. Both structures are innervated by primary afferents whose cell bodies are in the same dorsal root ganglia at spinal segments C3, C4.
Right.
So inputs from both the diaphragm and the skin over the shoulder converge onto spinal neurons in those C3, C4 segments of the spinal cord. Now, because your brain is primarily wired and accustomed to receiving sensory input from the skin, when those shared spinal neurons are activated by input coming from the diaphragm, the brain misinterprets the signal. It projects the sensation to the corresponding skin region, in this case, the shoulder.
So inflammation of the diaphragm, maybe from pleurisy or something, might not feel like pain deep in your chest where the diaphragm actually is.
Yeah.
You feel it as pain in your shoulder. That spatial mythlocalization is referred pain.
Precisely. It's a direct consequence of those shared pathways in the spinal cord and the brain's default assumption, if you will, that incoming signals from those particular spinal segments must be coming from the spin.
Fascinating. Okay, so from the spinal cord, the signal ascends towards the brain. What are the key pathways involved in getting it up there?
The majority of those second-order spinal pain neurons send their axons across the midline. They cross over to the opposite side of the spinal cord, and then they ascend upwards towards the thalamus in the brain.
Okay.
This ascending bundle of axons forms the main highway for pain and temperature information, and it's known as the spinothalamic tract.
And is this pathway absolutely crucial for consciously feeling pain?
Absolutely. The sources are clear on this. Interruption of the spinothalamic tract, maybe from a stroke or a spinal cord lesion, produces permanent deficits in pain and temperature discrimination on the contralateral, the opposite side of the body below the level of the lesion. It's the primary route for getting that raw sensory information about pain and temperature up to higher brain centers.
But the experience of pain is obviously more than just a raw signal saying, ouch, that's hot, or
Yeah.
ouch, that's sharp. How does the brain transform that signal into the complex feeling of suffering, the unpleasantness?
Right. From the thalamus, the signal doesn't just go to one single pain center. It diverges, projecting to multiple areas of the cerebral cortex, and each area seems to contribute to a different dimension of the pain experience.
Like what?
Well, one major projection goes to the somatosensory cortex areas called S1 and S2. This area processes the sensory discriminative aspects of pain. It allows you to locate the pain precisely on your body, judge its intensity, and describe its quality, as burning, stabbing, aching, the what and where of the pain.
Okay, the factual detail.
Exactly. But other thalamic neurons project to areas that are intimately involved in emotional processing and behavior, like the cingulate cortex and the insular cortex. These areas are thought to be responsible for the effective or unpleasant emotional dimension of pain. The suffering, the fear, the urge to escape, the way pain controls our behavior.
So that's where the awfulness comes from.
That seems to be a big part of it. Our sources highlight that lesions to certain areas of the frontal cortex involved in these circuits can drastically alter the emotional response to pain. People might still recognize the noxious stimulus and locate it, but the associated suffering or urgency is dramatically reduced.
That's incredible.
Yeah.
You could still feel the sensation, but not the accompanying fear or suffering. That really separates the physical feeling from the emotional response at the brain level.
It really does. It underscores just how distributed and multidimensional the pain experience is once it reaches the brain.
Which brings us to a really fascinating aspect: pain modulation. Why is it that two people with seemingly identical injuries can report vastly different levels of pain? Or why can soldiers in battle, for example, sustain severe injuries and initially report little to no pain, only for it to become excruciating later?
This is where the brain's remarkable power to modulate or control pain comes into play. Pain perception is not a fixed passive recording of tissue damage. It's dynamically shaped by psychological factors and by descending brain circuits.
How so?
Well, suggestion, famously demonstrated by the placebo effect, can powerfully decrease pain. Just the belief that a treatment will work can actually reduce pain. Conversely, the expectation of pain, sometimes called the nocebo effect, can actually increase it. Your state of mind, your beliefs, your emotions, they significantly impact how much pain you feel.
So the brain isn't just receiving the signal, it's actively editing it. What are these modulating circuits? How does the brain turn the volume down or up?
There are powerful descending pathways originating in brainstem structures. These structures themselves are influenced by higher centers like the hypothalamus and parts of the cortex. These pathways project down to the spinal cord, back to those dorsal horn neurons we talked about. And they can either inhibit or facilitate the transmission of pain signals at that very first synapse. They can basically tell the spinal cord, turn down the pain signal or turn it up.
And there's scientific evidence for this. We can actually see which parts of the brain are involved.
Yes, brain imaging techniques like fMRI have been crucial here. Studies clearly show that when pain is reduced by a placebo effect, specific brain areas light up. These include regions in the prefrontal cortex, like the dorsolateral prefrontal cortex, DLPFC, the rostral anterior cingulate cortex, RACC, and key brainstem areas like the rostral ventral medulla, RVM, and the periaqueductal gray, PAGA, as well as the hypothalamus.
Wow.
And critically, the activity in this circuit is linked to the body's own internal pain control system, one that uses opioid peptides. This placebo-induced analgesia can actually be reversed by naloxone, which is an opioid blocker.
So wait, part of the placebo effect for pain is literally your brain releasing its own opioids, like its own internal morphine.
That's what the evidence strongly suggests, yes.
Right.
These structures within this modulating circuit contain endogenous opioid peptides, natural painkillers your body produces like enkephalins and beta-endorphin.
That's amazing. How can you activate this internal opioid system, besides taking a sugar pill, I mean?
Well, the most reliable activators identified seem to be the suggestion of pain relief itself, the psychological component of placebo, and also intense emotional states that direct attention away from the pain. Think severe threat, intense fear, or the adrenaline rush of intense athletic competition.
Right, like the soldier on the battlefield example.
Exactly. These endogenous opioids are measurable in cerebrospinal fluid after surgery, and they are released in response to placebo administration in experimental pain studies.
Okay, but if the brain can turn pain down, can it also turn it up? Is there a facilitation side to this?
Absolutely. It's not just about inhibition. The same modulating circuits contain not just pain-inhibiting neurons, but also pain-facilitating neurons, particularly originating in the medulla and projecting down to the spinal cord. While the primary role of the descending system is often thought to be inhibitory, these pathways can also enhance pain transmission.
Enhance it.
There's even a theoretical possibility, supported by some research, that powerful activation of these facilitating pathways could potentially generate a pain signal in the spinal cord without any ongoing peripheral stimulus, without any actual tissue damage happening at that moment.
That's profound.
Yeah.
Could that help explain conditions like phantom limb pain or certain types of chronic pain where there's no obvious ongoing injury?
It certainly offers a framework for understanding some of these centralized pain conditions. For example, in migraine headaches, imaging studies often show increased activity in these brainstem modulating circuits. It could also explain how psychological factors like fear, anxiety, or negative expectation, the nocebo effect, can amplify or even seem to generate chronic pain signals. A central circuit capable of facilitating pain provides a powerful mechanism for how the brain itself can contribute to making pain worse or keeping it going long after an initial injury has healed.
This brings us neatly to a particularly challenging category of pain: neuropathic pain. Our sources describe it as a paradox. Damage to the very pathways that carry pain signals can somehow cause pain, rather than just leading to a loss of sensation.
It does seem counterintuitive, doesn't it? But it's a distinct and often debilitating type of pain. It arises as a direct consequence of a lesion or disease affecting the somatosensory nervous system itself. That could be the peripheral nerves out in your limbs, or the central nervous system pathways in the spinal cord or brain.
What kind of damage are we talking about? What causes this?
Well, common causes include injuries to peripheral nerves. Think diabetic neuropathy, which often affects the small nerve fibers in the feet and hands, or postherpetic neuralgia, the chronic pain that can linger sometimes for months or years after a shingles infection.
Okay.
It can also result from damage within the central nervous system, maybe trauma or a vascular injury like a stroke affecting the spinal cord, the brainstem, or the thalamus, which is that key relay station we mentioned.
And does it feel different than the pain you'd get from, say, a sprained ankle or a cut?
It very much does, typically. Neuropathic pain often has characteristic qualities that patients describe as burning, tingling, shooting, or electric shock-like.
Ouch.
Yeah. And a key feature is that it can occur spontaneously, just out of the blue, without any ongoing stimulus. Or it can be triggered by stimuli that wouldn't normally be painful at all, like a very light touch, the brush of clothing, or even a cool breeze. These spontaneous pains or pains evoked by normally non-painful stimuli are hallmarks.
So when you're examining someone, what might tip you off that they could have neuropathic pain?
You often find objective evidence of nerve damage in the affected area. This could be a sensory deficit, maybe reduced ability to feel light touch, temperature changes, or vibration. But two key positive findings are hyperpathia and allodynia.
We mentioned allodynia before with sensitization.
Right. Hyperpathia is an exaggerated, prolonged, and often unpleasant pain response to a stimulus, especially if it's repeated. And allodynia, as we discussed, is particularly telling in neuropathic pain. It can present as exquisite pain evoked by a stimulus that should be completely innocuous, like very light stroking of the skin. Our sources specifically note that topical lidocaine, delivered via a patch, can be highly effective for postherpetic neuralgia where allodynia is prominent. This suggests its mechanism targets those sensitized nerve endings right in the skin.
So what's actually going on at the cellular level to cause this paradoxical pain from nerve damage? Why does damaging a nerve make it hurt?
It's complex, and there are multiple contributing mechanisms happening both in the damaged peripheral nerves and within the central nervous system. Damaged primary afferent neurons, instead of just becoming silent, can become highly sensitive and start to generate spontaneous electrical impulses, basically, firing off pain signals all on their own without being stimulated.
Why would they do that?
Well, part of it seems to involve changes in the nerve membrane itself, including an increased density of sodium channels, which are critical for nerve firing. So the nerve becomes sort of electrically unstable. These damaged fibers can also acquire sensitivity to neurotransmitters they wouldn't normally respond to, like norepinephrine, which is released by the sympathetic nervous system.
Oh, okay.
Meanwhile, back in the spinal cord, neurons that have lost their normal input because the peripheral nerve supplying them is damaged can also become spontaneously hyperactive. They sort of start firing on their own because they're not getting their usual signals. So it's often a combination of peripheral nerve hyperactivity and central nervous system hyperactivity that contributes to neuropathic pain.
And there's a specific type of neuropathic pain that's often linked to the sympathetic nervous system, right?
Mhm.
Part of complex regional pain syndrome, or CRPS.
Yes, CRPS. That's a particularly challenging syndrome. It often develops after an injury, sometimes even a minor one, but the pain seems completely out of proportion to the initial trauma, and it involves other features like changes in skin color, temperature, and swelling.
What are the types?
There's CRPS type 2, sometimes called post-traumatic neuralgia or causalgia, which occurs after an identified nerve injury. But there's also CRPS type I, historically called reflex sympathetic dystrophy or RSD, which occurs seemingly without an obvious major nerve injury, though there's often a preceding trauma like a sprain or fracture.
What are the typical symptoms of CRPS?
Spontaneous burning pain is very common, and it can sometimes have a delayed onset, appearing hours or even weeks after the initial event. It's frequently associated with signs of autonomic dysfunction and inflammation in the affected limb. Things like swelling, changes in skin temperature, maybe the limb feels hot or cold, changes in skin color, maybe excessive sweating. And over time, you can even see changes like periarticular bone loss on x-rays and arthritic changes in the nearby joints.
And what's the sympathetic nervous system connection?
Well, early in the course of CRPS, the pain can sometimes be dramatically relieved by a sympathetic nerve block, an injection that temporarily blocks the sympathetic nerve supplying that limb. The exact pathophysiology isn't fully understood, but one leading theory is that activity in the sympathetic nervous system can somehow activate or exacerbate the activity of those already sensitized nociceptors, particularly when inflammation is present.
So sympathetic nerves might be talking to pain nerves when they shouldn't be.
Something like that seems to be happening, at least in some patients, especially early on. The sources emphasize the importance of looking for signs of sympathetic hyperactivity, those changes in sweating, temperature, color in patients who have post-traumatic pain and inflammation that just doesn't fit a simple injury pattern.
Okay. So understanding these different pain types and their underlying mechanisms, from basic nociceptive signals and sensitization to centralized pain and these complex neuropathic changes, is absolutely crucial for effective treatment. Which brings us finally to how we actually manage pain. What's the overarching principle here?
Well, the ideal, obviously, is always to remove the underlying cause of the pain if possible. If you break a bone, you set it. If you have an infection, you treat it with antibiotics. While assessing the etiology, the cause, is critical and should be done promptly. Initiating rapid and effective pain relief should happen concurrently, especially for severe pain. You don't want people suffering unnecessarily while you're figuring things out. And analgesic medications are typically the first line of attack in those acute, severe situations.
Right. Let's start with the most common group. The non-narcotic analgesics like aspirin, acetaminophen, Tylenol, and the NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen.
Yeah, these are incredibly widely used, many available over the counter. Their primary mechanism of action, with the notable exception of acetaminophen, involves inhibiting enzymes called cyclooxygenases or COX enzymes.
And what do COX enzymes do?
They're involved in producing prostaglandins, which are key mediators of inflammation and pain sensitization. So by inhibiting COX, these drugs reduce prostaglandin production. Many of them also have direct anti-inflammatory effects, particularly at higher doses, which is really key for pain associated with inflammation. They are definitely the go-to for mild to moderate pain like headaches or musculoskeletal aches and pains.
But they're not without risks, are they? Especially with regular or long-term use.
Absolutely not. With chronic use, gastrointestinal irritation is a significant concern for aspirin and other NSAIDs. Aspirin is particularly problematic because it also irreversibly inhibits platelet function, which increases the risk of GI bleeding and ulceration.
Okay.
Nephrotoxicity damage to the kidneys is another serious risk with chronic NSAID use, especially in vulnerable patients like those who are dehydrated or have underlying kidney issues. And NSAIDs can also contribute to increased blood pressure, so that needs monitoring during long-term therapy.
Acetaminophen seems to have a different risk profile, though.
It does. Acetaminophen rarely causes gastric irritation and doesn't interfere with platelets, making it safer in those regards. However, its major toxicity risk is severe liver damage, particularly at high doses or in combination with alcohol. So, dose limits are extremely important with acetaminophen.
Our sources also mention parenteral NSAIDs, the ones that can be injected, like ketorolac and diclofenac. Are they more potent?
They are quite potent, yes, and have a rapid onset when given intravenously or intramuscularly. They can be effective enough to actually supplant or replace opioids for many patients dealing with acute severe pain, like post-operative pain, acute headache, or musculoskeletal pain. That's a valuable tool because it can help reduce overall opioid exposure.
You mentioned COX enzymes. I understand there are different types, COX-1 and COX-2.
That's right. Broadly speaking, COX-1 is considered a constitutive enzyme, meaning it's present pretty much all the time in various tissues and involved in normal housekeeping functions, things like protecting the stomach lining, maintaining kidney function, and helping platelets aggregate or stick together. COX-2, on the other hand, is mainly an inducible enzyme. Its production is significantly ramped up specifically at sites of inflammation, where it plays a major role in producing those inflammatory prostaglandins that cause pain and swelling.
And that distinction led to the development of COX-2 selective inhibitors, drugs like celecoxib, Celebrex.
Exactly. The idea was brilliant, really. Create drugs that selectively block the COX-2 enzyme at inflammatory sites, providing pain relief and anti-inflammatory effects, while sparing the protective COX-1 enzyme, particularly in the stomach. The hope was to reduce the risk of GI side effects like ulcers and bleeding.
And did they work? Less stomach irritation.
They did. They are effective for analgesia and inflammation, and they do generally cause less gastric irritation than the traditional non-selective NSAIDs. However, they haven't shown a reduced risk for kidney toxicity.
But there was another problem, wasn't there? Cardiovascular risk.
Yes, that was the major issue that emerged. Large studies found that COX-2 selective inhibitors significantly increase the risk of serious cardiovascular events, things like heart attack, stroke, blood clots, and heart failure. One COX-2 inhibitor, rofecoxib, Vioxx, was withdrawn from the market entirely. Celecoxib remains available but carries warnings. They are now generally contraindicated after coronary artery bypass surgery and require significant caution in patients with existing cardiovascular risk factors.
So targeting just COX-2 solved one problem, but unfortunately created another significant risk. And you mentioned the non-selective NSAIDs like aspirin are problematic after surgery too because of bleeding risk.
Correct, because they inhibit platelet function. The sources know that among the common non-selective NSAIDs, naproxen appears to be associated with the least cardiovascular risk, though it still carries a higher risk of GI bleeding compared to the COX-2 inhibitors. It's a trade-off.
Okay. Now let's talk about the heavy hitters, opioid analgesics, morphine, oxycodone, fentanyl, etc. These are considered the most powerful pain relievers we have.
They absolutely are. Opioids are the most potent analgesics available. They have the broadest efficacy across different types and intensities of pain, and they are generally very reliable for providing rapid relief, especially for severe acute pain.
But they come with a well-known range of side effects.
They do. Many common side effects are reversible and include things like nausea, vomiting, itching, pruritus, sedation or drowsiness, and constipation, which is almost universally experienced with regular opioid use and needs active management.
And the most serious risk.
The most serious, potentially life-threatening side effect is respiratory depression slowed or stopped breathing. While this is uncommon at appropriate medical doses in otherwise healthy individuals, it requires careful monitoring, especially in patients who already have underlying breathing issues or when opioids are combined with other sedating drugs.
What are the warning signs?
Early signs are often a decreased respiratory rate and increasing sedation. A drop in oxygen saturation levels is a critical later warning sign. Newer monitoring techniques like capnography, which measures exhaled carbon dioxide, can detect decreased airflow and apnea even earlier. If significant respiratory depression occurs, it's often reversible with the opioid antagonist naloxone, Narcan, but it requires prompt recognition and sometimes ventilatory support.
And then there's the huge public concern about addiction. How did the sources address that?
They address it directly. The fear of patients becoming addicted when opioids are used appropriately for legitimate medical purposes, even for chronic non-cancer pain, is often significantly overblown compared to the actual risk. The chance is generally small, though the sources do note that the risk appears to increase with dose escalation, particularly in the context of chronic non-cancer pain. But for acute severe pain, the sources clearly emphasize that physicians should not hesitate to use opioids when they are indicated due to fear of addiction.
How exactly do opioids work to relieve pain? What's their mechanism?
Their primary actions are within the central nervous system, the brain, and spinal cord. They do two main things. First, they activate descending pain inhibitory neurons that project from the brainstem down to the spinal cord. These pathways essentially tell the spinal cord to turn down the pain signal.
Okay.
Second, they directly inhibit the pain transmission neurons in the dorsal horn of the spinal cord itself, making them less likely to fire and send the pain message up to the brain. Most clinically used opioids exert their effects primarily by binding to a specific type of opioid receptor called the mu-opioid receptor, which is found in high concentrations in these pain pathways.
And different opioid drugs vary quite a bit, don't they? In potency, how fast they work, how long they last.
Yes. They differ significantly in their potency, their onset of action, their duration of effect, and how they can be administered. Some also have active metabolites that can cause unique side effects.
Like meperidine.
Right, meperidine demerol is a good example. It produces a metabolite called normeperidine, which can build up, especially in patients with kidney failure or those on high doses over time. Normeperidine is actually a CNS stimulant and can cause hyperexcitability, tremors, and even seizures. Importantly, this neurotoxicity from normeperidine is not reversed by naloxone. For this reason, meperidine is generally not recommended for routine or prolonged pain management anymore.
Good to know. What about the different ways opioids can be given? Routes of administration.
Well, the intravenous Mirade route provides the most rapid pain relief, which is crucial for managing acute severe pain, like right after surgery or a major injury. Oral administration is slower, but much more convenient for moderate or chronic pain management at home.
And spinal administration.
Spinal administration, injecting opioids directly into the space around the spinal cord, either intrathecal into the cerebrospinal fluid or epidural into the epidural space just outside the dura, allows for much lower doses to be effective because the drug is delivered right to the target receptors in the spinal cord. This minimizes systemic side effects like sedation, nausea, and especially respiratory depression. It's commonly used during labor and delivery for postoperative pain management, and sometimes via implanted pumps for continuous infusion in intractable cancer pain.
Are there other routes?
Yes, other routes mentioned include intranasal sprays like butorphanol, rectal suppositories, transdermal patches like fentanyl or buprenorphine, which provide steady drug levels over many hours or days, and transmucosal formulations like fentanyl lollipops or films that dissolve in the mouth for rapid absorption.
Dosing seems like it would be tricky, given that patient response varies so much.
It absolutely does. There's enormous variability in how individuals respond to opioids, both in terms of pain relief and side effects. A very common clinical error is prescribing an inadequate initial dose, leaving the patient in significant pain. The key is really to titrate the dose and the frequency of administration based on the patient's individual response. You need to find the optimal balance between pain relief and manageable side effects.
So reassessment is key.
Prompt and frequent reassessment is crucial, especially when initiating therapy. If the initial dose doesn't provide satisfactory relief within a reasonable time frame, repeating it or adjusting it is often appropriate. It's also critically important to be aware of the potential for synergistic respiratory depression when combining opioids with other central nervous system depressants like benzodiazepines, Valium, Xanax, or alcohol. This combination should generally be avoided, especially in outpatients.
Patient-controlled analgesia, or PCA, was developed partly to help manage that individual variability after surgery, right?
Yes, PCA is a standard method, particularly in the postoperative setting or for patients with intractable pain like cancer pain who are hospitalized. It uses a computerized pump connected to an IV line. The pump is programmed to deliver a small, predetermined bolus dose of opioid, like morphine, hydromorphone, or fentanyl, whenever the patient feels they need it, simply by pressing a button.
Are there safety features?
Absolutely. The device is programmed with important safety limits, including a minimum lockout period between doses to prevent the patient from accidentally giving themselves too much too quickly. Sometimes there's also a limit on the total dose that can be administered within a set time period, like an hour or 4 hours. You typically give a loading dose first to get the pain under some initial control before starting the PCA.
What about a continuous background infusion with PCA?
While a continuous baseline infusion is sometimes added to the patient-triggered boluses, the sources note that it hasn't been definitively shown to improve pain control compared to bolus-only PCA, and it clearly increases the risk of respiratory depression. So it's often avoided or used with extreme caution and enhanced monitoring.
Now, our sources also mention something interesting. Peripherally acting opioid antagonists. That sounds like a way to block some opioid effects without blocking the pain relief.
Exactly. These are clever drugs. Medications like oral alvamopan or subcutaneous methylnaltrexone are designed to bind to mu-opioid receptors that are located in the periphery, for example, in the gut, but they do not cross the blood-brain barrier in significant amounts.
So they don't get into the brain.
Right. This means they can reverse or prevent unwanted peripheral side effects of opioids, such as delayed bowel function, ileus, after surgery, or the very common problem of opioid-induced constipation, without reversing the central analgesic effects that are providing the pain relief. Albumopan is used short-term in hospitals for post-operative ileus, and methylnaltrexone is used for opioid-induced constipation in patients on chronic opioid therapy, often for cancer pain or palliative care.
What about combining opioids with non-opioid analgesics like acetaminophen or NSAIDs? Is that a good strategy?
It often is. Combining opioids with COX inhibitors can be very beneficial. The analgesia is often additive or even synergistic, meaning you get better pain relief than you would expect from simply adding the effects of the two drugs together. But importantly, their major side effects are generally non-additive. Opioids don't cause GI bleeding or kidney problems like NSAIDs, and NSAIDs don't cause respiratory depression or constipation like opioids. So by combining them, you might be able to achieve good pain control using lower doses of both drugs, potentially reducing the risk of dose-dependent side effects from either component.
That makes sense. Is there a downside?
Well, there's a specific caveat with fixed-ratio combination pills like Percocet, oxycodone acetaminophen, or Vicodin, hydrocodone acetaminophen. If a patient needs to significantly escalate the dose of the combination product to control worsening pain, they might inadvertently ingest a dangerously high, potentially liver-toxic dose of acetaminophen without realizing it. Because of this risk, many practitioners now prefer to prescribe the opioid and the non-opioid components separately, allowing for more flexible dosing.
Right. That seems safer. Okay, let's shift gears now to chronic pain management. This feels like a fundamentally different challenge compared to managing acute pain from an injury or surgery.
It absolutely is. Chronic pain, typically defined as pain lasting longer than 3 to 6 months or beyond the expected healing time for an injury, can become a complex disease entity in its own right. Sometimes it persists without a clear, ongoing, initiating cause, as we see in conditions like fibromyalgia.
Yeah.
The mechanisms perpetuating chronic pain are often hard to determine and frequently involve those central nervous system changes we talked about, like central sensitization or dysfunctional pain modulation. These patients can be very challenging for clinicians. They're often understandably demanding, emotionally distraught because of the constant pain and its impact on their lives, and the traditional medical approach of searching for an obscure underlying physical pathology is often fruitless or even unhelpful.
So, if just searching for a single cause isn't always the answer, what approaches are effective for managing chronic pain?
The sources strongly emphasize the value of a broader approach. This includes psychological evaluation and the use of behaviorally based treatment paradigms. Approaches that help patients learn coping strategies, engage in functional rehabilitation despite the pain, and utilize cognitive restructuring techniques can be highly effective.
Where do people get this kind of care?
These comprehensive approaches are often best delivered in specialized, multidisciplinary pain management centers. These centers bring together physicians from various specialties like anesthesia, neurology, physiatry, psychologists, physical therapists, occupational therapists, and other specialists all under one roof to address the different facets of the patient's pain experience. Unfortunately, these comprehensive centers and approaches are often underutilized.
What are some of the key factors that can contribute to perpetuate or worsen chronic pain? It's not always just one thing, is it?
Rarely just one thing. You can broadly categorize the contributing factors. First, there might be an underlying, often incurable disease process that's causing ongoing tissue damage or inflammation. Think severe arthritis, cancer, chronic daily headaches, fibromyalgia, or persistent diabetic neuropathy.
Okay.
Second, there can be secondary perpetuating factors that persist even after the initial cause might have resolved. These could include things like ongoing nerve damage from the initial injury, persistent sympathetic nervous system hyperactivity, like in CRPS, or chronic muscle spasm and the development of myofascial trigger points.
And the third category.
And third, and critically important, are psychological conditions, particularly depression and anxiety, which are incredibly common in people with chronic pain. These conditions can significantly amplify the perception of pain, reduce coping ability, and sometimes even seem to be a primary driver of the chronic pain syndrome itself.
So taking a really comprehensive history is absolutely key, looking far beyond just the physical symptoms.
Absolutely vital. You have to ask specifically about depression, mood changes, loss of interest, changes in appetite or weight, sleep disturbances, difficulty falling asleep, staying asleep or sleeping too much, fatigue, feelings of worthlessness or guilt, difficulty concentrating, and thoughts of death or suicide. Tools like the Beck Depression Inventory can be useful screening tools, and it's critical to remember that major depression is a serious, treatable, and potentially fatal illness in its own right and must be addressed directly.
Are there other psychological clues in the history that might be relevant?
Yes, sometimes patterns emerge. Things like pain being reported in multiple, seemingly unrelated body sites, or a history of recurrent pain problems starting way back in childhood or adolescence. Sometimes the pain onset coincided with a significant emotional trauma, like a death in the family or a job loss. A history of physical or sexual abuse is unfortunately common in chronic pain populations. And current or past substance abuse issues are also important red flags. Identifying these factors isn't about dismissing the patient's pain. It's about understanding all the factors that are influencing their pain experience and identifying potentially treatable contributors.
The physical examination for chronic pain? What specific things are you looking for beyond the basics?
Beyond the standard neurological and musculoskeletal exam, you want to look specifically for signs that suggest a mechanical component to the pain. Is there guarding? Are they protecting the painful area? Are they avoiding certain movements or postures that seem to provoke the pain? Deep tenderness when you palpate muscles, ligaments, or joints can be indicative of ongoing inflammation or sensitization.
What about myofascial pain? Trigger points.
Chronic myofascial pain is very common. You're looking for localized trigger points, those distinct, often palpable, firm bands or knots within a muscle that are exquisitely tender when pressed, and importantly, often refer pain in a characteristic pattern elsewhere. Injecting these specific trigger points with a small amount of local anesthetic can sometimes provide both diagnostic confirmation, if the pain referral pattern is reproduced and then relieved, and temporary therapeutic relief.
And how do you specifically look for clues suggesting a neuropathic component on exam in a chronic pain patient?
You're looking again for those objective signs of nerve damage in the area where they report pain. Is there impaired sensation, numbness, pins and needles, altered feeling to touch or temperature? Do they have allodynia pain to light touch? Or hyperpathia, that exaggerated response? Is there any weakness or muscle atrophy, wasting in a pattern consistent with nerve injury? Are there deep tendon reflexes diminished or absent in that limb?
And clues for sympathetic involvement, like in CRPS.
You'll look for that characteristic cluster of symptoms we discussed. The diffuse pain and tenderness, swelling, and those changes in the skin color, temperature, texture, sweating, and potentially joint changes in the affected extremity. While a positive response to a sympathetic nerve block can be highly suggestive, especially early on, the response can be variable and less reliable in chronic, long-standing CRPS, so you rely more on the clinical picture and those objective signs of sympathetic hyperactivity or dysregulation.
So it seems the guiding principle in assessing chronic pain is to evaluate the emotional and the somatic factors together, right from the very start.
This is perhaps one of the most critical principles in effective chronic pain management. Addressing both aspects concurrently, even if you strongly suspect a predominantly physical cause, is crucial for building trust and ensuring the patient feels heard and validated. It assures the patient that you are taking their pain seriously and not suggesting it's all in their head. Even when there's a clear somatic cause, like metastatic cancer causing bone pain, other factors like associated nerve damage from the tumor or coexisting depression or anxiety can be significantly amplifying the overall suffering. The optimal therapy really aims to treat each contributing factor identified.
So once you've done that comprehensive assessment, what does a typical chronic pain treatment plan look like?
It needs to be explicit, ideally developed in partnership with the patient, and must include specific, realistic functional goals. These goals shouldn't just be about reducing a number on a Bain scale, but about improving function in their daily life. Things like being able to sleep through the night, go grocery shopping independently, return to some form of work or volunteering, walk the dog, play with grandchildren. The focus shifts towards function and quality of life.
And the treatments themselves.
Treatment approaches are often, and ideally, multidisciplinary. This might involve a combination of carefully selected medications, psychological counseling, or cognitive behavioral therapy, CBT. Structured physical therapy or exercise programs, sometimes nerve blocks or injections, occasionally surgery if there's a clear surgically correctable lesion, and increasingly minimally invasive procedures.
What are some of those minimally invasive procedures used for chronic pain?
Image-guided techniques are common now. For example, epidural steroid injections are often used for acute radicular pain. That's pain radiating down a limb due to nerve root irritation, perhaps from a herniated disc. Another common procedure is radiofrequency ablation, where heat is used to target the small nerves that supply sensation to specific joints, like the facet joints in the spine, which are a common cause of chronic back pain.
And what about for the most severe, intractable chronic pain that just hasn't responded to these less invasive approaches?
That's when more advanced, invasive neuromodulation techniques might be considered, but only in carefully selected patients. These include implanting electrodes to electrically stimulate peripheral nerves near the site of pain, or placing stimulating electrodes near the spinal cord itself, spinal cord stimulation targeting nerve roots, or the dorsal columns with the aim of disrupting the abnormal pain signals.
No.
Another option for very severe intractable pain, often cancer pain, is implanted intrathecal drug delivery systems. These are small pumps surgically implanted under the skin that deliver tiny, continuous doses of analgesic medication, often an opioid like morphine or hydromorphone, sometimes combined with a local anesthetic like bupivacaine, directly into the cerebrospinal fluid surrounding the spinal cord. This allows for potent pain relief with much lower total drug doses and fewer systemic side effects.
Are these common?
These are generally reserved for patients who have failed to find adequate relief with less invasive treatments. The sources strongly recommend referral to a comprehensive multidisciplinary pain clinic for a thorough evaluation before proceeding with these kinds of invasive procedures.
Right. Let's dive a bit deeper now into the pharmacologic management specifically for chronic pain, because it involves some drug classes you might not immediately associate with pain relief, like antidepressants. Why are they used?
They do seem counterintuitive based on their name, don't they? But certain antidepressants, particularly the older tricyclic antidepressants, TCAs, like nortriptyline and disopramine, have proven very effective for many types of chronic pain, especially neuropathic pain conditions like diabetic neuropathy or postherpetic neuralgia.
How do they work for pain? Is it just by treating underlying depression?
No, interestingly, their analgesic effect seems to be independent of their antidepressant effect. It often occurs faster within days or weeks rather than weeks or months, and at lower doses than typically required to treat depression. And they can work even if the patient isn't clinically depressed at all. The mechanism is thought to involve blocking the reuptake of norepinephrine and serotonin in those descending pain-modulating pathways we discussed earlier, essentially boosting the brain's own pain-inhibiting systems.
And can they work well alongside opioids?
Yes, they can potentiate or enhance opioid analgesia. This makes them useful adjuncts for managing severe chronic pain, such as cancer pain, potentially allowing for lower opioid doses. However, TCAs come with a significant burden of dose-related side effects that can be problematic, especially in older patients.
What kinds of side effects?
Things like dry mouth, constipation, urinary retention, drowsiness, dizziness, especially orthostatic hypotension when standing up, blurred vision, and sometimes cardiac conduction delays or memory impairment. These side effects can also be additive with opioids, which also cause drowsiness, dizziness, and constipation.
Are there newer antidepressants used for pain that might have fewer side effects?
Yes. While the SSRIs, selective serotonin reuptake inhibitors like fluoxetine Prozac, generally have fewer side effects than TCAs, they are also generally considered less effective for pain, probably because they don't have as much effect on norepinephrine.
Okay.
However, the SNRIs, serotonin norepinephrine reuptake inhibitors like venlafaxine, Effexor, and especially duloxetine, Cymbalta, block the reuptake of both serotonin and norepinephrine, similar in mechanism to how TCAs are thought to work for pain, but generally have a more favorable side effect profile than the TCAs. Duloxetine in particular is FDA approved for several chronic pain conditions, including diabetic neuropathy, fibromyalgia, and chronic musculoskeletal pain.
So they might be a better choice sometimes.
They often are, especially if TCAs aren't tolerated. They typically cause less sedation than TCAs or some of the anticonvulsants we'll discuss, and may be preferred as first-line agents, particularly in elderly patients or in people whose work or daily activities require a high level of mental alertness.
Okay. Anticonvulsants or anti-seizure medications are also frequently used, again, primarily for neuropathic pain.
Correct. The older anticonvulsants like phenytoin, Dilantin, and especially carbamazepine, Tegretol, were historically the first-line treatments for trigeminal neuralgia, which is characterized by those brief, intense, electric shock-like or lancinating facial pains. They are thought to work primarily by stabilizing nerve membranes and reducing abnormal spontaneous firing of damaged nerves.
And what about the newer ones that are very widely used now, like gabapentin, Neurontin, and pregabalin Lyrica?
Gabapentin and pregabalin belong to a class called calcium channel alpha-2 delta ligands. They work differently than the older agents. They are effective for a much broader range of neuropathic pains than the older anticonvulsants conditions like diabetic neuropathy, postherpetic neuralgia, fibromyalgia, and neuropathic pain after spinal cord injury. They also generally have a more favorable side effect profile, although sedation and dizziness can still occur. Because of their efficacy and tolerability, they are very often used as first-line agents for many types of neuropathic pain.
What about antiarrhythmics, drugs used for heart rhythm problems?
Systemic antiarrhythmics like lidocaine, given intravenously, usually as a test infusion, or its oral relative mexiletine, have shown less consistent effectiveness for chronic neuropathic pain compared to antidepressants or gabapentinoids. 4-lidocaine can sometimes provide temporary relief and predict response to other membrane stabilizers, but oral mexiletine is often poorly tolerated due to significant gastrointestinal side effects. It's worth noting that achieving significant pain relief with anticonvulsants often requires titrating up to relatively high doses, and sedation can be a common dose-limiting side effect for many of them.
Cannabinoids are increasingly discussed in the context of pain. What did the source materials say about their role?
The sources we reviewed indicate that cannabinoids have shown modest analgesic effects in some studies. Interestingly, some research suggests they may be more effective at reducing the unpleasantness or the emotional suffering component of pain, rather than reducing the raw sensory intensity itself. They are also, of course, well established for reducing chemotherapy-induced nausea and vomiting. Research is ongoing, and regulations vary widely.
Okay. And then we come to the very complex and often controversial topic of chronic opioid medication for non-cancer pain.
This is indeed a very challenging area for clinicians and patients alike. While chronic opioid therapy is widely accepted and often absolutely necessary for managing moderate to severe cancer pain, its use for chronic non-malignant pain remains highly controversial, despite opioids being, as we've said, the most potent and broadly effective analgesics available.
Why the controversy? What are the major risks?
The risks are significant and well documented. Tolerance, the need for higher doses over time to achieve the same effect, and physical dependence, the occurrence of withdrawal symptoms if the drug is stopped abruptly, are highly likely, essentially expected, with long-term daily opioid use. While true addiction defined as compulsive drug use despite harm, loss of control, preoccupation is thought to be relatively rare when opioids are initiated appropriately solely for pain management, the risk certainly exists and appears to increase with higher doses and longer duration of therapy, especially in patients with other risk factors.
And there's another potential issue. Opioid-induced hyperalgesia.
Yes, that's another concern. There's growing evidence for a phenomenon called opioid-induced hyperalgesia, OIH, where paradoxically, chronic opioid use can actually make patients more sensitive to pain, potentially worsening their overall pain problem over time. The mechanisms aren't fully clear, but seem to involve some of those central sensitization pathways we discussed.
So it's absolutely essential to have a very frank discussion about all these potential risks and limitations with patients before starting chronic opioid therapy.
Absolutely critical. Patients need to understand the potential downsides, the likelihood of tolerance and dependence, the risk of addiction, even if small, the possibility of OIH, and the expected side effects like constipation. Other non-opioid treatment options should always be fully explored and optimized first. Informed consent is paramount. It's also important to avoid using mixed agonist-antagonist opioids like butorphanol or nalbuphine or pentazocine in patients who are already physically dependent on full agonist opioids like morphine or oxycodone, as these mixed agents can precipitate a very unpleasant and sometimes dangerous withdrawal syndrome.
For patients who are candidates for long-term outpatient opioid therapy, are there preferred types of opioids or formulations?
For managing chronic, relatively constant pain, long-acting opioid formulations or intrinsically long-acting compounds are often preferred. The rationale is that they provide more steady plasma drug levels throughout the day, which can minimize the peaks and troughs associated with short-acting opioids. This might lead to more consistent pain control, fewer side effects related to peak levels, and less reinforcement of drug-taking behavior compared to the rapid ups and downs of short-acting agents.
What are some examples?
Examples include intrinsically long-acting drugs like levorphanol or methadone, or extended-release ER or SR formulations of drugs like morphine, oxycodone, or hydromorphone, as well as transdermal patches like fentanyl or buprenorphine. However, it's important to note that many extended-release formulations are specifically indicated only for patients who are already opioid tolerant, meaning they've been taking opioids regularly for at least a week, and they are generally not recommended as first-line agents for opioid-naive patients due to the higher overdose risk if dosed incorrectly.
What about short-acting opioids? Do they have a role in chronic pain?
Yes, short-acting opioids might be more suitable, sometimes used on an as-needed basis, for managing intermittent severe episodic pain flares, often called breakthrough pain, that occur on top of a baseline level of chronic pain that might be managed with other therapies, or a long-acting opioid.
And that nearly universal side effect we mentioned, constipation,
Mm-hmm.
needs constant attention.
It really does. It is indeed almost universal with chronic opioid use, unlike some other side effects like nausea or sedation, which often lessen over time. Opioid-induced constipation, OIC, typically persists and must be anticipated and treated proactively from the start, usually with a scheduled bowel regimen involving stimulant laxatives and/or stool softeners. The peripherally acting opioid antagonists we discussed earlier, like methylnaltrexone, are particularly useful for refractory OIC as they can specifically reverse the opioid effect in the gut without affecting the central pain relief.
The source material rightly places this whole discussion within the context of the ongoing opioid crisis.
It does, and it's impossible to discuss chronic opioid therapy without acknowledging that context. The sources note the dramatic increase in opioid prescribing, misuse, addiction, and overdose deaths that began in the late 1990s and early 2000s, coinciding partly with the widespread introduction and marketing of extended-release oxycodone, OxyContin. This led to significant public health responses, including enhanced prescription drug monitoring programs, PDMPs, those statewide electronic databases that track controlled substance prescriptions.
Right.
Increased law enforcement efforts targeting illicit diversion and prescribing, the development of clinical practice guidelines from organizations like the CDC, and reports from various federal task forces aimed at improving pain care while mitigating opioid-related risks.
What do these guidelines, like the 2016 CDC guideline for prescribing opioids for chronic pain, generally cover? What's the gist?
They provide recommendations primarily for primary care clinicians regarding several key aspects. When should you even initiate or continue opioids for chronic pain? The guideline strongly emphasizes that opioids should only be considered if the expected benefits for both pain and function are anticipated to outweigh the substantial risks, and only after non-opioid therapies have been tried and optimized. How do you select the appropriate opioid dosage duration? How frequently should you follow up? When and how should you consider tapering or discontinuing opioids? And critically, how do you assess and mitigate the risks, including the risk of misuse, addiction, and overdose?
So they provide a framework, but the decision is still clinical judgment.
Exactly. While the guidelines provide a structured approach and emphasize caution, the ultimate decision to initiate or continue chronic opioid therapy rests with the individual practitioner, weighing the specific risks and potential benefits for that individual patient. The sources include tables summarizing pragmatic guidelines based on these principles. They cover things like careful patient selection criteria, including a thorough history, physical exam, appropriate diagnostic testing, and maybe using formal tools to assess abuse risk. They stress the importance of establishing clear treatment goals focused on function, not just pain scores.
And informed consent and monitoring.
Absolutely crucial. A detailed discussion of the goals, expected benefits, potential risks, including tolerance, dependence, addictions, side effects, overdoses, and alternative treatment options is essential. A written treatment agreement or pain contract outlining responsibilities can be useful. Initiation often involves a trial period, starting with low doses of short-acting opioids and titrating carefully based on response and side effects. And ongoing monitoring is perhaps the cornerstone of safe chronic opioid therapy.
What does that monitoring involve?
It involves periodic reassessment, typically at least every 1 to 3 months of the 4As, analgesia, pain relief, activity, functional improvement, adverse effects, and aberrant drug-related behaviors. Are the treatment goals being met? Is function improving? Are side effects manageable? Is the patient adhering to the plan? Monitoring tools include patient self-report, checking the state PDMP database to see if the patient is getting controlled substances from other prescribers, and performing periodic urine drug screens.
Urine drug screens. Are they recommended for everyone?
The guidelines suggest performing urine drug screens periodically, especially in patients deemed higher risk or those exhibiting concerning behaviors, but also considering them periodically in all patients on chronic opioid therapy to help confirm adherence to the prescribed regimen and detect potential undisclosed substance use that could increase risks.
The guidelines also mention specific dosage thresholds to be aware of.
Yes, they highlight the concept of calculating the total daily opioid dose in morphine milligram equivalents, MME, per day. This allows you to standardize the dose across different opioid drugs. The CDC guideline noted that doses exceeding 50 MME day are associated with a significantly increased risk of overdose and warrant more frequent follow-up, careful consideration of risks versus benefits, and offering naloxone for overdose reversal. They strongly recommend avoiding increasing doses to 90 MME day or higher, or, if such doses are deemed necessary, carefully justifying the decision and strongly considering referral to a pain specialist.
And the decision to continue.
The decision to continue chronic opioids at each follow-up visit should be based on demonstrating meaningful, ongoing improvement in both pain and function compared to baseline, with the benefits continuing to outweigh the risks. If that's not the case, or if significant risks or harms emerge, like signs of sedation, overdose risk factors, or suspected opioid use disorder, then tapering or stopping the opioids is indicated, often with referral for addiction treatment if needed.
Okay, so synthesizing all these treatment approaches for chronic pain, it sounds like the strategy needs to be highly individualized and almost always involves multiple different types of treatments combined.
Exactly. There's rarely a single magic bullet for chronic pain. The goal is to tailor the treatment plan to the individual patient's specific pain type. Nociceptive, neuropathic, mixed. Identify and address all contributing factors, physical, psychological, social. Provide reasonable relief, minimize side effects, and maximize function and quality of life.
Can you give some examples of how you might combine therapies for, say, neuropathic pain?
Sure. For neuropathic pain, as we discussed, first-line pharmacologic options often include either the gabapentinoids, gabapentin or pregabalin, or certain antidepressants like duloxetine, venlafaxine, nortriptyline, or desipramine. Topical lidocaine patches can be very helpful for localized cutaneous hypersensitivity, like in postherpetic neuralgia, providing relief right at the site with minimal systemic absorption or side effects.
And if one of those doesn't work well enough?
Then you might switch to an agent from the other first-line class, or, very commonly, you might combine an antidepressant with a gabapentinoid, as they have different mechanisms of action and can sometimes work synergistically. Opioids, as mentioned, are generally considered second or third line for neuropathic pain because of their side effect profile, the potential for tolerance or reduced efficacy over time, and that risk of OIH. Newer agents like tramadol and tapentadol, which have mixed mechanisms, weak opioid agonists plus serotonin or rapinephrine reuptake inhibition, might also be considered. And sometimes you might add non-pharmacologic therapies like physical therapy, TES, transcutaneous electrical nerve stimulation, or psychological approaches like CBT or mindfulness. Botulinum toxin injections are also emerging as a potential treatment for certain types of focal neuropathic pain. The key is combination therapy and individualization.
It certainly sounds like managing chronic pain effectively requires a very deep understanding of all these complex mechanisms we've discussed and a real willingness on the part of the clinician to employ a wide range of tools and often work as part of a team.
Absolutely. And ultimately, the sources bring us right back to the fundamental responsibility of the physician and indeed any healthcare provider to do everything possible to minimize both the physical discomfort and the emotional suffering of the patient. Patients seek our care primarily because they are suffering. Having a solid familiarity with these intricate pain mechanisms and the diverse range of analgesic strategies available pharmacologic, interventional, psychological, rehabilitative is absolutely key to fulfilling that fundamental responsibility.
We have covered a truly vast amount of ground in this deep dive today. I mean, from the microscopic world of peripheral nociceptors, their ion channels, the chemicals they release, through the spinal cord's complex processing, convergence, and the brain's incredibly powerful ability to modulate the signal both up and down, all the way to understanding distinct types of pain like neuropathic pain and CRPS, and navigating the complex, often challenging multidisciplinary world of pain management strategies, both pharmacologic and procedural, for both acute and chronic pain.
It really fundamentally reinforces that pain is not just a simple linear signal of damage to pain. It's a dynamic, incredibly multifaceted experience, profoundly influenced by the state of the entire nervous system, the emotional landscape of the individual, and even their expectations and beliefs.
Yeah, understanding those nuances, the difference between a nociceptor being activated by an acute injury versus a nerve fiber becoming spontaneously active and hypersensitive in neuropathic pain, or appreciating the distinct risks and benefits of an NSAI versus an opioid versus an antidepressant when choosing a medication for pain, that level of understanding is absolutely essential for truly effective assessment and management. You need that depth to make good clinical decisions.
And I think the discussion around chronic pain particularly highlights the necessity of looking beyond just a single physical cause, embracing a truly holistic biopsychosocial approach that considers psychological factors, functional goals, and the proven power of multidisciplinary care.
So what does all of this mean for you as a listener, now armed with this much deeper understanding of pain? Perhaps the most striking takeaway for me is just how incredibly malleable your experience of pain actually is, mediated by those complex circuits in your own brain. That your brain possesses the machinery to actively turn the pain volume up or down, responding even to things as subtle as expectation or as powerful as your emotional state. It really reveals that while the initial signal originating from your tissues might be real, your conscious experience of suffering is remarkably dynamic and adaptable. This isn't meant to imply it's all in your head in a dismissive way, but rather to emphasize that your head, your brain, is an incredibly powerful and integral part of the entire pain system itself, capable of both amplifying and suppressing the experience.
Well said.
With all we've explored today, delving deep into the mechanisms and management of pain, what single insight or concept about pain stands out most to you from this deep dive?